Good morning, good afternoon, good evening, everyone. We are going to wait 1 or 2 more minutes to let folks join. We're expecting a lot of participation today, which is very exciting, and we will get started very soon. As you join, if you want to introduce yourself in the chat with your name, your country that you're joining from, and your organization. And thanks to those who have already started. We're excited to see who's joining today. All right, I will go ahead and get started with some introductions and a few housekeeping items so that we can get started and jump to everyone's presentations, which we're very excited to share with you today. So I will start with an introduction of myself. Good morning, good afternoon, good evening. My name is Lindsay Miller. I'm a Senior Technical Management Officer at JPIGO, working on the Momentum Country and Global Leadership Project. I am based in Washington, D.C., and I am joined by several colleagues today who help lead the MIYCN-FP-Immunization community of practice. And that's who convened the meeting that you all are joining today, and we're excited that you're here. A bit about our community of practice. We came together a few years ago to look at the issues of integration and how we can support integrated services to provide quality comprehensive care. And so our community of practice meets twice a year for a global meeting, a global convening, and this is the first time we're actually meeting in a year. So we're really excited that you're here, and we have a lot of exciting updates to share. So next, a few housekeeping reminders. We recommend, if you're not already using a headset, to have one on. It helps reduce background noise, especially given the number of participants that we're expecting today, and because we're going to have several interactive sessions where we hope to hear from you. So we hope that cameras come on at some point and that you unmute at some point and help join those conversations. Please feel free to use the chat box as you are freely to either ask questions during a presentation, to ask questions to myself, the moderator, or to the organizers who I'm joined by if you have technology issues. Due to time constraints, we won't be having a traditional Q&A after each presentation, but as presenters see the chat box or as a follow-up, they may be able to help answer questions there. And we are also saving the chat for any follow-up after the meeting. Please feel free to direct message Shantae or Matea you should see for any technological issues. or just in the chat box, which will also be monitored. The meeting is being recorded, and we will share the recording afterwards. And most importantly, we have live French interpretation that is taking place throughout the meeting. And so it's important for everyone, especially our speakers today, and it's a good reminder to myself to speak slowly, clearly, and somewhat loudly so we can all hear, and to allow for our Francophone colleagues to fully participate. And yes, please continue to introduce yourself in the chat box. Next slide. This is just a reminder where, if you are interested in hearing French interpretation, where you can turn on the interpretation and make sure that you have your audio settings that allow for that. Great, let's get started. Next slide. So we are going to start this morning with some global updates from our nutrition, family planning, and immunization colleagues. We wanted to provide a global update since we hadn't met since October 2021. There have been a lot of exciting happenings in each technical area. So this is going to be a quick snapshot of what's going on globally in our 3 technical areas. And we're starting off with my colleague, Peggy. Peggy, do you want to introduce yourself and get started, please?
Sure. Actually, we're going to start with Sasha, Lindsay. Over to you, Sasha.
Okay, great. Next slide, please. Oh, and I'll just introduce myself. I'm a senior technical advisor with USAID Advancing Nutrition. And I have tried to throw together, I have to actually give recognition to our colleague, Haptamu, and I'm going to say his last name wrong, who helped put together these slides from Save the Children and the Momentum Project. I'm sure many of you on here know Haptamu. So yeah, give recognition to him. I am really pleased to be doing this. I am sure I'm not covering all of the latest, but these are a few things just to keep in mind. And I invite other nutrition colleagues on here to add in the chat any other of these latest things that are happening that I might miss. So one is just to mention that this big every 4-year conference is happening this year. So there's a lot of attention being given to this. The MIYCN conference, and it's going to be in Tokyo. There's several themes, but I thought it would be worth pointing out these few. The Nutrition Through Life course, and I think that is kind of relevant to our conversations today, and the integration. And oops, I'm seeing the chat pop up. And nutrition and management of diseases. I also think, that fits within our integration. Food culture practices and nutrition education. I feel like that's another. And then public health, nutrition, and environment. So I really tried to focus here on those that I thought lent themselves to the integration. Next slide. So one of the other things I wanted to mention, and this is maybe me being biased towards strengthening systems for nutrition, are quite a few things that I would sort of put into that bucket. Increased attention is being given to counseling and communication skills and strengthening those. As you all probably know, nutrition is a big piece of nutrition is behavior change, and encouraging that behavior change through proper counseling and support skills. So a lot of attention is being given to this lately through various means. And I think Peggy will talk about a little bit of that. And I know within USAID Advancing Nutrition, we're focusing on that as well. Another is small and sick newborns and children with disabilities. So strengthening services that meet their needs. So again, sort of strengthening the systems and services, integration of nutrition services with responsive care and early learning. I think that could fit nicely with, at least with immunization services. And then pre-service training of health workers up on the screen are two things. Alive and Thrive recently published this article on integrating competency-focused maternal, infant, and young child nutrition content in the curriculum for nurses, or I'm missing now what it's specific. Yeah, for health workers in general. And then we at Advancing Nutrition have been doing something kind of similar of reviewing curricula for frontline service providers to see that, sort of as a first step to check the extent to which nutrition is covered. And then if you click again, Lindsay or maybe Kristen, I think something should pop up. Yes. And then the other is, thank you. Sorry for the animation. The other is exploring the use of digital tools. I know this is sort of a, maybe it's a fad, but hopefully it's not. And hopefully it is helpful for improving quality of care. But so this is something we've been doing, and I apologize for being USAID Advancing Nutrition centric. It's what I know best at this point. My nose is to the grindstone. And I think, so those are a few things. I'm sure I've missed plenty. I welcome others to throw out other topics that are really big in the nutrition world. I see that Altrina came on, so I welcome you and Peggy also. And with that, Peggy, I'll turn it over to Peggy Konas-Boer. Oh, no, I was supposed to cover this one too. Sorry. One other big thing is new WHO recommendations on maternal and newborn care for a positive postnatal experience. I'm assuming that many of you have heard about this, but the thing I wanted to point out was that there are 63 recommendations included, 11 are nutrition related. So you know, there's prominence to some extent being given to nutrition in these new recommendations. So it's well overdue, an update to these, and so we're glad to see this come out. I think I'm going to flip right through. There's 2 more slides, or maybe even 3 on these different recommendations. I think we'll share these slides, and so I think I'll pass so you can click 2 more times, and then I'll pass it over to Peggy, just in the spirit of time. So Peggy, over to you, please.
Great, Sasha, thanks so much. Hi, everyone. I just wanted to quickly share that JSI is currently supporting Unicef in updating its generic community infant and young child feeding counseling package, which is made up of 9 components, including planning, training, and counseling tools that were developed between 2010 and 2012. According to Unicef, elements of this package have been adapted and are being used in over 90 countries. The current generic package includes 1 card specifically focused on promoting optimal child spacing and family planning methods, and other cards highlight the importance of childhood immunization. Next. There are 24 individual counseling cards and 3 others focused on special circumstances, but the 24 are focused on key integrated infant and young child feeding and nurturing care concepts. Next. And I very quickly want to share that this community of practice, the MIYCN Family Planning and Immunization Community of Practice, inspired the 2019 update to the Rwanda package, which includes a new counseling card highlighting the importance of immunization and emphasizing the timing of infant and young child feeding practices, immunization schedules, and developmental milestones. We are hoping to include an improved version of this card in the updated Unicef package so that other countries will be encouraged to consider this program integration opportunity. And we'll be looking to members of this community of practice for technical inputs and feedback. And then over to the next colleague. Anne. Thank you.
Thanks, Peggy. Thanks, Sasha. My name is Anne Fitzer, and I lead the Momentum Country and Global Leadership Family Planning work. I, like Sasha, have a challenge of thinking, go ahead, Kristen, you can go to the next slide, of what to share with this diverse group that would be of interest. I think, you know, we've we're still a little bit in the transition period between what was FP 2020 and what is now FP 2030. And there is some interesting new work there that I will share, and then some quick announcements. And then my colleagues, Katie and Emeka will share about the high impact practice. Anyway, we can go to the next slide. For those of you who are not family planning 100% of the time, like some of us, let me just say that FP 2030 is really trying to bring us together as a community of family planning stakeholders in this unifying partnership around a very gender affirming, gender empowering vision that includes all genders, not just men and women. And I think it's giving us fresh energy for that work in this new decade. We have a new leader of the partnership with Dr. Samu, and I think it's exciting to have her voice and passion for family planning and reproductive health. I invite you to watch webinars on the FP 2030 website if you're interested to hear her speak. And then we have this new regional structure that's trying to shift power from Washington, where I sit, to the various continents around the world. And we have new regional hubs in Africa, and more coming in Asia and Latin America and the Caribbean. And there will be, it says next slide, but I inserted some new slides. I think there'll be a new measurement framework that we can talk about. So I think what's different in this decade of FP 2030 is this idea of strengthening progress and acceleration of access and use of contraceptives with this accountability framework that was just released. And actually, I have to give a lot of credit to my colleague, Angela Mutunga, who helped the team at FP 2030 in its development. And this is centered around the idea that countries that join the partnership make commitments, and that those commitments sort of drive the rest of us accountability towards it. It's also a guide. This framework is a guide for these regional hubs that are around the different continents in the globe, and it's supposed to help all of us develop stronger advocacy agendas that are aligned and unified. Next slide. So the greatest idea under this framework is that at the core, governments and civil society are working together collaboratively to advance the work on the ground, and each have their role, and the collaboration is at the center. And then implementing partners like our project's Momentum or the donors should be aligning their work and their efforts to those country commitments, whether they're the government commitments or the civil society commitments. And then FP 2030 is sort of documenting and capturing all the progress through this measurement effort, which is validated by country stakeholders. And early in the process, next slide, we had some hints of this new measurement framework, which is super interesting. It evolved from the 2021 with a big shift on counting additional women who are using to more generally counting contraceptive use at the top, but also with some new indicators, and especially an emphasis on adolescent contraceptive use. And I'm so excited to see some youth leaders in our midst today. So the FP 2030 community or partnership does this measurement every year to give us some data and some ability to collectively follow what's happening in terms of progress. So those core indicators are pretty important. I think I'm going to stop here for time and hand it over to our immunization colleagues, and then you'll hear from Katie and Emeka. Rebecca, over to you.
Thanks so much, Ann. My name is Rebecca Fields. I am the Immunization Technical Lead for USAID's Momentum Routine Immunization Transformation and Equity Project. And I just want to take a few minutes to give a broad overview of some of the latest developments in immunization globally. Next slide, please. So just as Ann was describing sort of a global blueprint for family planning, we have a similar one in immunization. It is called the Immunization Agenda 2030. It was developed during the years of about 2019 through 2020. And of course, we've had a lot of things happen since then, with the pandemic. But this was a major undertaking spanning multiple agencies and with heavy country involvement to really try to identify the top priorities to pursue during the coming 10 years. And to set some targets. So just a couple of things I want to go over here. And I see that Matea has put the Immunization Agenda 2030 link into the chat box for your reference. The vision is a world where everyone, everywhere, at every age, so not just for child vaccination, fully benefits from vaccines for good health and well-being, with goals of reducing mortality and morbidity from vaccine-preventable diseases all across the life course, really improving equity, leaving no one behind, and ensuring good health and well-being for everyone by strengthening immunization within the context of primary health care and contributing to universal health coverage and sustainable development. The targets are as shown on the left here. And again, these targets were developed in late 2019, early 2020. So the targets are to achieve 90% coverage for essential vaccines given in childhood and adolescence. Also to cut in half the number of children who completely miss out on vaccines, and also to complete 500 national or subnational introductions of new or underutilized vaccines, including for COVID-19, as well as rotavirus and HPV. I think this slide is animated. Could you just advance? No, sorry, please go back. Right, okay, one thing I want to highlight here is if you look at this semicircle graphic, you'll see it's a little hard to read, but there are about 7 different priority areas that are shown here. The first is broad, it's immunization programs for primary health care and universal health coverage. But the one I want to draw your attention to is the one that in little letters says life course and integration. In other words, expanding immunization over the life course and really looking at that in terms of how to integrate it with other health services and health interventions is one of the priority areas for the Immunization Agenda 2030. Next slide, please. So just building that out a little bit, for this particular strategic priority area on life course and integration, the goal is that all people benefit from recommended immunizations over the life course, and as I mentioned earlier, effectively integrated with other essential health services. So that is quite relevant to what we're talking about today. The objectives are to strengthen immunization policies and service delivery throughout the life course, including for catch-up vaccination, which has become more prominent as an issue over the past several months, and for booster doses, and also to establish integrated delivery points of contact between immunization and other public health interventions for different target groups. Next slide, please. So how are we doing? Well, again, this plan was finalized in 2020. But already we are seeing major challenges. At the top here, what you see is the headline for a press release that came out from WHO and Unicef just about a month and a half ago in July of this year, just after new annual data of coverage estimates had been issued by WHO and Unicef. And as you can see here, it says, COVID-19 pandemic fuels the largest continued backslide in vaccinations in 3 decades. WHO and UNICEF sound the alarm. because of this continued decline. What we saw overall globally across all countries is that coverage dropped from 86% in 2019 to 81% in 2021. And, this may still look pretty high. But actually, we have, several large countries where coverage has fallen greatly. We've got the highest number of unvaccinated children since 2009. The number of completely missed children increased by 5 million over the past 2 years. Drops in HPV coverage. And also only 25, not 500, vaccine introductions other than COVID-19 were reported in 2021. Next slide, please. Of course, during the past year and a half, we've seen a massive rollout of COVID-19 vaccine. I'm just going to go through this quickly. The rollout has been successful in many places, and it's pushed immunization partners to think about reaching groups that we've missed in the past. However, it's stretched human resources. There have been initial pushes to get vaccination of COVID out through mass campaigns, but we're seeing a shift now in many countries to more integrated types of service delivery strategies. And my final slide is the next one. And we are seeing growing interest in integrating COVID-19 vaccination into routine immunization and into primary healthcare overall. But we also know that there are a lot of concerns as well as potential benefits for doing so. So in trying to do that type of integration, we need to look at how services are organized. We need to look at the implications for the health workforce and for supply chain management, for communication and acceptability and community engagement, certainly for data management, and for planning, budgeting, costs, and financial management overall. And I just want to mention here that WHO and Unicef just last month issued a draft document, a working document on considerations that countries should keep in mind if they are thinking about integrating COVID-19 vaccination into immunization programs and primary health care. It provides several examples of such experiences, as well as a checklist of considerations that countries should keep in mind if they are embarking on such integration. Thank you very much.
Thank you. Good morning, afternoon, and evening, everyone. My name is Emeka Nwachukwu. I work as Implementation Science Technical Advisor with the Office of Population and Reproductive Health at USAID in Washington, D.C. I support the HIPS partnership leading the measurement and metrics side of things. Myself and Katie will be talking about the high impact practices and especially how it affects family planning and immunization integration. Next slide. Right, for general interest and introduction, the high impact practices are evidence-based family planning practices that have been vetted by experts against specific criteria, documented in easy-to-use formats for use. It's a collaborative effort supported by over 65 organizations, but managed by a group called co-sponsors, which is USAID, Bill and Gates Foundation, MIYCN-FP, IPP network of WHO, and IPP, the family planning group. Okay, so the overall goal is to assist country-level decision makers in making informed decisions to achieve impact with efficient use of resources. And these targets mainly the USAID missions, governments, implementation partners, CSOs, and the family planning community interested in maximizing resources to improve family planning impact globally. Next slide. This is a website for the HIPS. There's a lot to talk about. These two slides in 2 minutes will not do it. I encourage colleagues in this meeting to go to this website and see a whole lot of resources that's available. But the HIPS has products which includes briefs, strategic planning guides, And there are webinars managed by IBP Network and invited papers written on interesting subjects. Currently, there are over 21 high impact pricing briefs grouped by category. The first category is enabling environment. Second one is service delivery, social behavioral change. There's also a group known as HIP enhancement, which are more like cross-cutting HIPs that supports implementation of the other HIPs. The service delivery and SBC briefs are further categorized by strength of evidence into proven and promising. There's an in-house developed tool called Grayscale that the technical advisory group that meets twice a year to consider the available evidence and approve the HIPs before they're put on the website, use this Grayscale to determine whether those are promising or proven. The next slides will discuss the family planning high impacts practice called family planning immunization integration, which is currently a promising brief. Over to you, Katie.
Great. Thank you so much, Emeka, for the background and context on the HIP briefs. I'll just be giving a brief update on the FP immunization integration HIP. So this was first developed in 2013 as a promising practice with a lot of support from this group or a predecessor to it. And then as part of a broader effort to update the HIP briefs, this update round began in 2020 with an open call for technical experts. I'm presenting on behalf of about 7 of us, plus support from the USAID HIP team, and the brief was just finalized in September 2021. Some of the key updates are that we looked at all of the evidence since the last brief, updated the evidence table and included it directly in the brief. One of the things we noted based on the evidence available in the original brief, there was sort of 2 main service delivery models that were described, and we felt like with the new evidence, we needed to update that to a little bit more nuance. A theory of change was added, as with all of the new HIP briefs, and some proposed indicators were added, which I'll talk about next. Of particular interest to this group, we did discuss the inclusion of nutrition in addition to immunization and taking a life course approach. As Emeka noted, these are evidence briefs, so I think this is one of the cases where the discourse is kind of is out in advance of the evidence base. So for now, the brief is still on FP immunization in the postpartum period, but I think we hope that it will expand as the evidence expands. Next slide, please. Matea has added the briefs to the chat. This is just a quick thumbnail of the theory of change on the right. Some of the key aspects included in the left side. I think in particular, there is a large section on tips from implementation, because we've got a lot now that are organized in program design, implementation, and M&E. As I noted, there are 2 proposed indicators in this brief. I think no surprise to anyone here, integration indicators are complex. So just noting that these 2 are proposed indicators and we'll need some more research to validate. The updated brief is available currently in English, Spanish, and Portuguese. The French version has been completed and is currently under review and should be up within the next couple weeks. And I'm sure this group can help get that out. So check out the briefs. We don't have much time to go into any questions today, but there's a lot there. And thank you on behalf of everyone in this call who helped to make those. I'll hand it over to the next speaker. Thanks so much.
Great. Thank you to my colleagues for that very brief update across the 3 technical areas. I think that'll be a good background to our in-depth discussions that we hope to have in this next session. So I know that that was a lot of information very quickly, but we are sharing links to everything that speakers are sharing in the chat. So please be sure to check the chat. And I'm going to hand it over to Dr. Chizokin now.
Good morning, good afternoon, good evening, everyone. I'm Chizoba Wonodi. I'm the Director for Immunization for the Momentum Country and Global Leadership. Thank you, Lindsay, for the handoff. I'm really excited to moderate this next session that is going to give us an opportunity to deep dive a little bit more into integration. As you all know, integration has been long on the public health agenda, and it's been advocated for strongly because it's seen as a pragmatic approach to optimize health services and resources in order to provide efficient and effective care. But the reality is that in many countries, integration is not happening as it ought to be or as is envisioned to happen. So services remain verticalized, they remain fragmented, leading to inefficiencies and inability to manage our human, financial, and material resources effectively for health. So the massive rollout of COVID vaccine has really called more into question, and Rebecca mentioned this, the need for better integration. And so today we want to share with you the findings of a landscape analysis that Momentum Country and Global Leadership conducted to look at integration of health services more in depth. And then we will also explore deeper by having a panel discussion of quite experienced colleagues from the 3 countries where this studies was done. So without much ado, it's my pleasure to invite Mr. Shiva Gabdaidem from Sidani Health Initiatives, who led the landscape analysis study, to present the findings of the landscape analysis, and then before we go into the panel discussion. So Shiva, over to you. Did you guys hear me? Oh, Shiva's microphone is muted. Let's see if we can unmute him.
Shante, is it possible to unmute Shiva?
Hi, everyone.
Yes. Oh, there we go.
Hi, everyone.
Hello,
it's great
welcome.
It's great to connect with you all. I am Mr. Shiva Gabdidam, a senior analyst at Sidani Initiative for International Development, and the team lead for the Integration Landscape Analysis Project. This is really an exciting moment for me because it's an opportunity to disseminate findings for a year-long project that we conducted across 3 countries. And to present these findings, we all understand that health integration has been on the agenda. In high-income countries, it's a lot more understood. But in low-income countries like Nigeria, Madagascar, Nepal, Tanzania, health integration is, the needle on health integration has not moved as much as it has in the other countries. And information is not at the fingertips of program planners and health administrators. Next slide. So these findings are, we had to do this landscape analysis to build a knowledge base for health integration in low and middle income countries as a means to build the evidence and develop a decision aid tool for health integration at the primary healthcare level. And in building this knowledge base, we sought to develop and conduct a landscape analysis. And this landscape analysis consists of a literature review and case studies in 3 low and middle income countries, Nigeria, Nepal, and Madagascar. Next slide, please. So first, we defined health integration. by adapting the WHO definition of integration as the management and delivery of health services so that people receive a continuum of health services coordinated across the different sites of care and according to their needs throughout the life course. Before my presentation, we've been talking about the life course, and in defining and looking at the possible models and possible ways that primary healthcare programs can be integrated, we profiled 3 of these, and we have integration of immunization into other health programs, excluding immunization. And to understand this deeper, for integration of immunization into other health programs, it's more around trying to improve the coverage of immunization in the countries or in the settings. And improving the coverage, immunization has to leverage other health programs such as family planning, prenatal and postnatal care, HIV, and all other health programs in that exist. And there are some examples. Specifically in Nigeria, this is really evident because, the previous presenter mentioned the findings that RI, that's routine immunization has reduced due to COVID-19 vaccinations. And here in Nigeria, through the development of the Scale 3.0 strategy, has now come up with an integrated approach for the deployment or the deployment of COVID-19 vaccines in the country. And then the other is integration of other health programs into immunization, where immunization is the main body, or it's the original backing, and then the other health programs are provided as incentives to deliver care at the facilities. And then integration of other health programs, we have integration of HIV, integration of other chronic non-communicable diseases. Next slide. So this landscape analysis seeks to achieve 4 objectives: to understand the extent of health integration in low and middle income countries, to explore the benefits and risks of clinical integration, and then to identify barriers and enabling factors for clinical integration in low and middle income countries. And then for these barriers that have been identified, to bring out recommendations or solutions to addressing these challenges. Next slide. So now to discuss the methodology for this assessment. This is speaking specifically to the literature review that was conducted. So for us to conduct this literature review, we adopted a systematic review approach, and we employed peer-reviewed articles and gray literature. We used such terms like health integration, lower middle income country, extent of integration, and we put these search terms into search databases, and we pulled out about 3,690 search outputs in form of references. And we screened this using the systematic approach like I mentioned, and we got down to 59 articles for our literature review. Next slide. So this is just a schema showing how we screen through the articles, and the 59, 48 were peer-reviewed articles and 11 were gray literature. The gray literature includes policies on health integration across some low and middle income countries. Next slide. So going into the findings, we're going to be discussing the findings across 5 key areas: the policies, the types of integration, the benefits of integration, the barriers and risks of integration, and the solutions that have been recommended by health program planners and researchers over time. The CDC policy framework to review the available policies online, and this framework assesses the policies, the limitations of these policies for health integration impact, And it does that across 3 levels. It reviews the public health impact, the economic and budgetary impact. And from this review, we found out that most of the policies in low and middle income countries, actually integration is on the policy agenda of low and middle income countries. And these policies have been found to have some level of implementation across the countries, and they've shown some public health impact. However, the budgets for these policies and programs, as well as the guidelines for the implementation of these programs, were not readily available online for our review. Types of integration. I'd already spoken to the 3 profiles that that we could glean from our literature review on the 3 different types of health integration. Benefits of health integration. It was found that from our study, we found that there are 4 key benefits for health integration. There's increased uptake of services, where you see that integration of immunization into other health programs increases immunization coverage, resource efficiency, increased capacity of healthcare workers, prevention and early detection of diseases. Now, integration on both ends, when in the context of immunization, either provides a support for other programs, or it's being supported by other programs, as we see in some integrated immunization strategies like OIRIS. Now, to the barriers of health integration, there are 6 key barriers, and these barriers are mostly structural barriers in terms of the number of healthcare workers and the capacity to be able to deliver integrated care, the level of funding that is being presented or earmarked by the countries for health integration. Of course, there's also this funding ties to inadequate supply of medical resources and equipment, and the lack of implemented policies and guidelines, clear guidelines for healthcare workers to be able to integrate care. And then, of course, there's the whole system, or the verticalized systems that have already been in existence, which affects monitoring and supervision of integrated care. And of course, poor community engagement. So we identified some risks, such as increased healthcare worker workload and inadvertent disclosure and stigma in cases of integration of programs such as HIV. And from our review, about 6 solutions were identified based on the barriers. So the first is the recruitment of healthcare workers and building their capacity and providing guidelines for these healthcare workers. These guidelines could be in form of SOPs, it could be in form of digital solutions for healthcare workers to be able to get recommendations for integrating care. And of course, providing the required financing and political buy-in and backing for release of funds for integrated programs. Going to the next slide. Yeah, so this review highlighted key gaps and opportunities for further work on health integration. And this answers the question of what should program planners focus on for health integration? What should governments focus on for health integration? What should development partners focus on for health integration? So it's across 3 prongs: integration, the development of policies and guidelines, implementation of these policies, and of course, monitoring and supervision for the implementation of integrated strategies in low and middle income countries. We found out that different policies exist in low and middle income countries, although these policies are only speaking to integration of 1 or 2 programs at the facilities. And of course, the development of these policies has to be backed by political will, has to be backed by funding for integrated care. And then for implementation, success and outcomes of integration is dependent on the capacity of healthcare workers. So here it's mostly talking about providing healthcare workers with the required tools, guidelines that they can use for integrating healthcare, and how are all these policies being implemented, especially at the lower levels of primary healthcare service delivery. And then for monitoring and supervision, the literature shows that there needs to be strong M&E systems, and M&E systems need to move towards integration as well. So the development of integrated M&E systems would support health integration in low and middle income countries. Next slide. So what should the key considerations for integration really be in low and middle income countries? Context, integration should be contextualized to the different countries. Each country has its own specific nuances, and that should be considered in designing health programs. Feasibility, trying to find a balance between what is ideal, a model that has been developed, and what is feasible for implementation. Compatibility, evidence shows that health interventions that are compatible with each other should be integrated together for higher success. Such interventions such as family planning and immunization, services around RMNCH that are typically coordinated or provided together or have the same target clients for health integration. And then accessibility of the interventions to the community, and that's the part of community engagement. That's where community engagement comes in designing the strategies for successful implementation. And of course, accountability for program managers in terms of ensuring that finances are being disbursed at the right time for integrated care. Next slide. Now to the limitations that we found from our study. So our study has three main limitations. First is that the articles from our literature review were only articles that were published in English, articles that were only available online. So that also affected the number of policies that we could find on health integration in our study. And of course, positive information on the implementation of most of these identified policies were not available online. And to make the study more robust, we went ahead to conduct key informant interviews across the three countries to understand more around the implementation of these policies. So with that, that's the end of my presentation. I'm looking forward to questions and comments.
Okay. Thank you so much, Shiva, for that excellent presentation. There is just so much in that report that we can't, unpack all of it today. So with that, I would like to bring up my panelists to even do a bit more unpacking for us from their country perspectives. So the first person I want to call on is, I will introduce all three of them. Next slide, please. Next slide. Okay, so here's the panelists that will do justice to digging deeper into introduction from a country perspective. So my first panelist is Dr. Sagar Dahal. He's the Chief of Health and Immunization Service Section in the Family Welfare Division, Department of Health Services in Nepal. He's here today with us. Dr. Dahal, we're really excited to have you on. I hope he's there.
Namaste, everyone. Hi.
Nice. Okay, great. Then the next person to introduce is Dr. Garba Bakunawa. He's the Principal Medical Officer for the National Primary Healthcare Development Agency, NPHCDA, in Nigeria. Dr. Bakunawa is currently the National Gavi Desk Officer at the agency. Dr. Bakunawa, nice to have you here.
Yeah, good morning.
Okay.
Good evening, everyone. Dr. Chizoba, good evening, everyone.
Thank you. And last but certainly not the least is Dr. Jean-Pierre Rakatovo. He is a senior he's a technical director at JPIGO, Madagascar, has decades of experience in public health, primary health care, and he's also trained as a gynecologist and a very dear colleague of ours that works with us in Madagascar. Dr. Jean-Pierre, you're very welcome. Okay. Dr. Jean-Pierre, are you there?
Oui, bien
Okay.
sûr, merci de l'introduction.
All right. So my first question is going to Dr. Bakunawa. Picking up a thread of discussion from what Shiva mentioned, where he talked about integration of services into immunization or integration of immunization into other programs. So from your experience in Nigeria, can you tell me, looking at services that have been either integrated into immunization or having immunization integrated into those other primary healthcare services, can you tell me what some of the benefits and risks of integrated services have been from your own practical experience? And then what are some of the best practices to make it work, and some of the lessons that you've learned in managing programs that are integrated?
Yeah, thank you very much, Dr. Chizoba. Thank you. Good afternoon, good morning, good evening, our participants. This is a very interesting topic, and this is one of the most important topics currently being discussed globally because of the effect of pandemic and other issues that globally we are facing as a community. So the benefit, there are a lot of benefit as well as risks to integration of services. However, before I say a word or two, there are a lot of integration that had been in the space of public health for a very long time, just like Dr. Chizoba mentioned from the beginning. So the first one, in the context of Nigeria, the integration has started long ago. We started with the integration of the PHC services, or using the integrated training packages like integrated training manual by Global Fund. We have also by other program of HIV/AIDS in the country. Then later, as a country, we also developed series of documents starting from the optimized integrated routine immunization session, OIRIS, and other interventions that recently joined the space of public health in Nigeria, especially with the coming of COVID-19. So we had a lot of approaches that we wanted to put in place to ensure that we have it right in terms of integrating of services. However, there are a lot of benefits that we have seen. And what pushed the country actually into the integration of those services to look at them in depth is the fact that with the coming of COVID-19, there are a lot of gaps around human resource for health. So human resource for health is one of the major challenges that we face as a country. So really to leverage on that, there is nothing we can do, but rather being the priority has been shifted to some of those programs because of the effect of pandemic. So we have to see like for countries to really leverage the platform of the human resource capacity gap to see how they can bring so many programs together, especially immunization and other PSC services. So that was the first thing that we noted around the benefit. So it will help to really bring the services together when they are really integrated. By integration, we will be able to have the program run together because of the challenge that we have for human resource for health. So that was number one. Then the second component that we also noted was around the finance. Because of the COVID-19, all of us, we believe that definitely we have to see, we have noted the tying of the effect around the economic space as well as the fiscal space. So based on that, we have to also bring the lens of integration, because through integration, we'll be able to bring, leverage the resources in one program to also implement the other programs. So those are some of the benefits that we also notice, yes, that by integration, we'll be able to leverage the resources that are in one program to really also leverage the resources to also implement other programs. This is seen in the case of the COVID-19, where we have resources for deployment of COVID-19. But we realize also that the same human resources that are used for immunization are the ones that are also delivering COVID-19. So what can we do? But rather to make sure that we carry along, especially routine immunization together with COVID-19 in an integrated fashion, so that we'll be able to have those activities really run through. So around the resources, this is another way. So the other aspect also, the still linked to resources, we can also leverage the resources from COVID-19 to also deploy some other routine services. For instance, like printings of data tools, deploying of other technologies, also to scale up like COVID-19 vaccination and other primary healthcare services. So those are some of the benefits that we have noted around this thing. So what are the risks? Just like we said, in terms of the risks, there are a lot of challenges. Still, the link is also a mirror of some of the images that we mentioned. One, we realize that there are a lot of gaps around human resource. So capacity is one of the issues. By the time you are also integrating program, so there may be around a capacity around the service providers. Some of them, they are really community health workers. So in terms of capacity, there are a lot of limitations. So for us really to make progress is also to look at around how are we going to improve their capacity. So one of the gaps that we have seen as a risk is also for us, we have to make sure that we improve their capacity, build their capacity for them really to run with the integration, because by just putting more program into the system without really building the capacity of the healthcare workers, then definitely you'll see a lot of gaps. So those are some of the things that we have noted around it. Then
Thank you, Dr. Baknawa. Sorry to cut you off because of time. I think that you've made some very interesting points. So the first one is the issue of, the benefits are that you're going to leverage human resources, you're going to leverage resources, but one of the risks is the capacity gaps, because you're piling on the same set of people. So I want to just, with that thread, move on to Dr. Saga to tell us, Dr. Saga, you've been listening to the conversation, right?
Yes.
Perhaps from your own perspective, using an example of an integrated program in your country, you've also heard some of the challenges that were mentioned from Nigeria. Can you tell us some of the challenges that you have experienced setting up and implementing an integrated programs, and what are the ways that you have devised to address those challenges, taking account of what has already been said?
Thank you for the question and the time. So far the integration is concerned, we understand integration after the Alma Ata conference of 1978. During that time, before that time, we used to have the vertical programs like the malaria control program, family planning program. The whole set of the implementation was totally vertical, and we approached to integrate all those things, delivering all these services through one unit, the primary healthcare unit. In our context, we have health posts, we have primary healthcare centers, we have hospitals, and most of these services were integrated. By 1993, we integrated all these services within those health facilities. This is one part of the integration. But later on, we realized that integrating those larger chunk into one health facility is not sufficient. And back in 5-10 years back, we started a debate that at that time, I used to work as a family planning section chief, national family planning manager. And I thought that the family planning access as well as the utilization could be increased if I could integrate this program into the immunization services. And at that time, what happened, we approached, we discussed, and the immunization service section felt a kind of threat that the success of the program was quite high, because compared to the family planning program, the immunization program was quite rich with very good coverage, and they felt threat that whether this integration might jeopardize or might hamper their program. So at that time we approached. So integrating immunization into other services and integrating other programs into immunization service was taken that way back in 10 years. I'm telling you the story of the 10 years back. And now what happened in 2020, we integrated the hygiene promotion services into the immunization sessions. And what we did might be interesting to all of you. What we did is we produced a case for that. We piloted something and we come up with the findings that, okay, this is doable, this can be done. So with that understanding and with that pilot implementation, the program realized that, yes, we can do it. And before that, we have integrated one thing very successfully into our program, in the immunization program, that we have integrated the growth monitoring, because during the immunization sessions, all the mothers used to come with their babies. So, even though we have not integrated the family planning and other services so well, but we have integrated the weighing of the children and growth monitoring program is well integrated into the immunization services. So after that, we have integrated the hygiene promotion behaviors. And for all these things, this is the acceptability as well as the trust of the program that this is doable, this will benefit, this will create a win-win kind of situation. And in the previous presentation, I also observed that immunization is the very good platform to integrate several things. And recently we are in a debate and we are discussing. Recently we had a workshop just a week ago, that what can be integrated into the immunization and what others program can take immunization into it. So, like for example, in nutrition program, we used to provide albendazole and the vitamin A supplementation to under 5 children. And as you know, in the previous presentation, I have also heard that that there is a in such programs, there are so many missed children in the immunization program. The issue of the missed children and those who have not received any dose or some of the doses has been missed. This is how the program can win. And we started a debate that why can't we integrate those things into while launching the vitamin A supplementation program or the albendazole campaign, because in that time all the under 5 children will be consulted. So we are exploring more and more ways and how to integrate. And for all these things, we are now in a phase that we understood that both the program can win, we can supplement each other. So integration at the health facility level becomes a challenging issue when you look at the workload. If you look at the immunization service and the growth monitoring services, in some of the immunization centers, what we have observed is that we cannot anticipate the same health workers without supporting them with some additional health workers. They cannot carry out both the functions in some of the health facilities, but most of the health facilities, they will be able to do that. So right. These are the things right. that needs to be taken care, and provided that first of all, right. The whatever is being integrated shall produce the case, shall convince the program that yes, it is doable. It will not hamper the program. It will produce the yield, the good result. That is what we have observed.
Okay, thank you so much. Thank you so much, Dr. Saga. First of all, pilot it, show that it's a win-win situation, convince the programs that it will work, and then be mindful of the burden on the health workers. Okay, great. So I'll move to my last panelist right now, JP. JP, you've heard what others have said. Maybe we can talk about some of the solutions right now, solutions for the barriers that have been mentioned or the challenges that have been mentioned around integration. So can you, from your experience, give us examples of maybe policies or approaches that really support the integration of immunization and address the challenges that we've mentioned in previous discussions?
Thank you, Chizoba. Merci beaucoup. Bonjour tout le monde. En fait, à Madagascar, il n'y a pas vraiment de politique de stratégie propre à l'intégration. Mais pourtant, il y a plusieurs socles qui pourraient favoriser l'intégration. En particulier, on a des documents de politique de stratégie comme la PDSS, plan de développement du secteur santé, dans lequel il est mentionné l'amélioration de l'accès universel à des services et soins essentiels intégrés de qualité pour tous, y compris les personnes enclavées indigentes, et stimulation de demande effective de services essentiels appropriés par la communauté. On a aussi le cadre d'investissement en santé reproductive, maternelle, néonatale, enfants et adolescents, et d'autres documents de politique comme les feuilles de route pour l'accélération de la réduction de la morbidité et de la mortalité maternelle. On a aussi des documents programmatiques et techniques comme les PCME au niveau des formations sanitaires communautaires, les différentes normes et procédures, et aussi des paquets de formation intégrés. On a même des structures pouvant favoriser l'intégration. Ce sont des structures de coordination au niveau national, par exemple, où on a des mécanismes de coordination de partenaires et même au sein du ministère de direction générale qui est en charge de la coordination des différentes directions qui pourraient aussi favoriser l'intégration. On a des différents groupes techniques de travail, en particulier pour les partenaires, ce qu'on appelle HA6+. Et au niveau régional, les DRS, les directions régionales de la santé, et au niveau district, le service de coordination, le service de district sanitaire. On a aussi des socles d'intégration transversale, comme le système intégré des données, de l'approche qualité avec l'humanisation des soins. Et au niveau des services, de la formation sanitaire, on a les CHU, les CHRD, où se trouvent déjà des services spécialisés dans un même lieu. Et surtout, au niveau de formation de base, on a des paquets d'activités intégrés qu'on pourra fournir en stratégie fixe, stratégie avancée, mobile. Et surtout, au niveau communautaire, il y avait des paquets d'activités intégrés. Je peux parler quand même qu'il y a quand même des obstacles, en plus de ce qui était mentionné par Dr Shiva, surtout cette partenariat inefficace entre les différents partenaires techniques et financiers qui crée une concurrence en défaveur de l'intégration. Il y a aussi cette relation entre le ministère de la Santé et les PTF. Le ministère, pas toujours facile pour lui d'assumer le leadership et il peut avoir la capacité et pas toujours la possibilité d'exercer cette capacité. Il y a d'autres obstacles structurels, mais ce qui était déjà mentionné par l'étude. Qu'est-ce qu'on peut faire pour essayer de solutionner tous ces obstacles? Il est vrai que l'intégration n'est pas une panacée, surtout si elle est mal organisée, non adaptée. Elle peut devenir même un facteur limitatif pour la performance. Pour moi, il faut que toutes les parties prenantes aient une compréhension commune et claire de l'intégration et aussi comprendre l'intégration dans le cadre des bénéfices de la population cible. Pour cela, il faut créer un environnement favorable à l'intégration, penser en termes de continuum d'intégration selon le système et selon le niveau, et aussi selon le parcours de développement professionnel. Parfois, on oublie que l'intégration concerne aussi bien la population cible, pour les besoins de la population cible, que les besoins des professionnels de la santé. et aussi, bien sûr, selon le cycle de vie pour la population. En fait, pour conclure, afin de satisfaire la définition de l'OMS sur l'intégration des services, il faut considérer plusieurs facteurs dont la compréhension, la nécessité et volonté pour une des tâches d'intégration. Le plus important, créer un environnement propice pour cette intégration. Merci beaucoup. Si vous avez des questions, je pourrais les répondre. Merci beaucoup, Dr. Chizoba.
Merci beaucoup, Jean-Pierre, and merci for keeping to time. So I'll now hand over to, and thank you so much to all the panelists for your excellent interventions. So we will go over to the breakout rooms, and the panelists will be there, and we can explore some more, ask questions that we were not able to cover here in the plenary. So I'm handing over to Lindsay to direct the next action. Lindsay, please. Thank you.
Great. Thank you, Chizoba. Thank you to our panelists. This has been a really interesting discussion, and I think it's going to kick off what we hope are very engaging discussions in breakout rooms. Next slide, please. Next slide. So what we hope to do now is to get together in smaller groups and breakout rooms and hear from you all. So we've provided a backdrop this morning at the beginning of the meeting of some of these larger global technical updates and what that might mean for our conversations around integrated services and what that means for comprehensive care. We've heard from our colleague Shiva around a specific study on integration, and we've heard from panelists on sort of what that means from their perspective and their experiences in their countries. And now we want to hear from all of you. So what we're going to do now is have 3 breakout rooms. The first room is going to stay here in this main plenary room, and this is where we invite all of our Francophone colleagues to stay. You will be joined by French-speaking moderators, including our panelist, Jean-Pierre. And so there will not be English translation in this main room. And this main room is going to be talking about policy broadly. So what does integration policy look like? What does it mean? How can we support it? The second breakout room is called service delivery. And you can choose, for English speakers, you can choose one of 2 rooms. One is service delivery, which is room 1. And the second room is around demand generation and trust in the health system. So you will be asked to choose a breakout room, and you will have approximately 25 to 30 minutes to have a discussion. We have some questions for you, and we'd like to have videos on. We're going to allow everyone to turn their videos on and to turn their microphones on. You'll be joined by moderators who have questions for you. For those who wish to stay in this plenary room, for our French-speaking colleagues, be sure to raise your hand. Use the function in the chat to raise your hand so that we don't accidentally push you to one of the other breakout rooms that will be in English. I will just wait for 1 minute just to see if we have any other questions in the chat about our next activity. Otherwise, please continue to select your breakout rooms. And we look forward to coming back together after the breakout rooms and discussing. And we have a lot more to share with you after this conversation.
Okay, I'm opening them now.
Thanks, Shantae.
Ok. Bonjour. Est-ce que je suis dans dans le bon groupe.
Ouais, Jean-Pierre, tu restes avec nous dans la plénière.
Ok.
Et
Ok,
on
merci.
va démarrer dans 1 minute, mais je voulais donner l'occasion aux anglophones de retrouver leur salle. Donc, ne fais rien pour l'instant. Les francophones, vous pouvez rester avec nous. Mathéa, si vous n'arrivez pas à choisir votre salle, Mathéa va vous aider. Enfin, I should say that in English. If you can't find your room, enfin bref, je crois que je vais les laisser faire eux-mêmes. Ils savent ce qu'ils font. So those of you who are Anglophone and still with us, you should have the breakout room window open and you can pick, if you're still unassigned, and you can pick either the health system governance or the service delivery room, just, scroll down to those and click join the one you want to go to. Bon, je crois qu'on va démarrer. Donc, encore une fois, peut-être je vais allumer ma vidéo. Encore une fois, nous sommes là avec Jean-Pierre, c'est Anne Fitzer, je vais baisser ma main peut-être. Et on est là pour une discussion, donc n'hésitez pas d'ouvrir vos micros, d'allumer vos caméras si vous êtes à l'aise avec ça. Et on va discuter du thème des politiques pour l'intégration des services. Je crois que Jean-Pierre a parlé de certains défis, certaines solutions qui sont en opération à Madagascar, mais aussi certains défis. Donc, est-ce que quelqu'un veut poser des questions à Jean-Pierre pour démarrer? Mais sinon, les questions qu'on va débattre, c'est concernant ces politiques d'intégration. Est-ce qu'elles sont mises en œuvre? Et quel système de redevabilité devrait être mis en place pour vraiment s'assurer que ces politiques d'intégration sont appliquées à l'échelle? Est-ce que quelqu'un veut parler? Maintenant, les mains sont levées. Je ne sais pas si c'est parce que vous voulez rester dans la salle francophone ou si c'est parce que vous voulez parler. Donc, ne vous inquiétez pas. Ouvrez le micro et on va discuter.
Merci Anne. J'avais demandé une question, c'est Magdalena Serpa, à Jean-Pierre un peu sur le problème budgétaire qui est un problème très grave pour l'intégration. Il a donné des idées, mais est-ce que peut-être, Dr. Jean-Pierre, vous voulez continuer, s'il vous plaît?
Merci Magdalena. Comme nous avons vu dans le résultat de l'enquête faite par Dr. Shiva, le côté finance est vraiment un obstacle pour l'intégration. Chaque partenaire apporte son fonds qui devrait normalement donc aider le ministère à mettre en œuvre les interventions. Mais ce fonds n'est pas forcément donné au ministère et même c'est le partenaire qui prend en charge pour la gestion de ce fonds. Donc, si le ministère, j'allais dire, impose aux partenaires que voilà, vous avez votre mandat ici concernant la santé maternelle, l'autre aussi, la même chose, on va mettre ensemble l'argent dans qu'on appelle basket fund et nous allons gérer ensemble et mettre en œuvre ensemble les interventions concernant la santé maternelle ou bien l'APF. Ça, c'est une solution. Et aussi, l'autre, c'est que parfois, on demande aux instances décentralisées de monter leur propre plan de microplanification. La plupart du temps, ces microplans est déjà un processus d'intégration pour les interventions. Mais l'argent est toujours resté au niveau central et les régions, les districts n'ont pas la possibilité de mettre en œuvre leur plan à cause du manque de financement. Donc, comment faire pour que l'argent arrive à ces niveaux décentralisés? Peut-être d'autres pays ont des expériences dans ce sens, on aimerait bien les attendre. Comment ils ont fait pour amener l'argent du niveau central au niveau décentralisé? Merci.
Merci Jean-Pierre.
Merci. Est-ce que d'autres veulent intervenir sur ce sujet? Est-ce qu'il y a d'autres pays qui ont réussi à débloquer les ressources pour l'intégration des services au niveau décentralisé? Ou bien, quel serait... Les gens sont timides.
Bonjour.
Oui, allez-y.
Bonjour, Karine Jacquin, je suis avec Intrahealth. Le projet Inspire en Afrique francophone de l'Ouest a mis en place des groupes de travail techniques. Je ne suis pas une experte dans la description même du projet, mais je sais qu'ils ont fait un effort significatif pour assurer l'institutionnalisation de l'intégration à travers ces groupes de travail techniques qui sont parrainés par le ministère de la Santé et sur lequel aussi reposent tous les partenaires techniques du pays. Et c'est à travers ce système centralisé qu'ils ont identifié les districts et régions qui pourraient commencer à mettre en œuvre des modèles d'intégration de santé maternelle, néonatale et infantile, planning familial, nutrition et vaccination. Et ça semble bien marcher. Et pour l'instant, ils ont fait ça, je crois, dans 6 ou 9 pays, je ne sais plus. En tout cas, le partenariat de Ouagadougou.
Merci Karine. Je vois que Isidore est là et il a la main levée. Je crois que Isidore, vous êtes de ce projet aussi, n'est-ce pas?
Oui, exactement,
super.
exactement.
Je ne t'avais pas vu, Isidore, désolé.
Oui, donc c'est pas grave. Je crois que vous l'avez bien signifié. Effectivement, comme l'a dit mon précédent, nous travaillons avec des groupes techniques de travail, effectivement, dans les 9 pays de partenariat de Ouagadougou. Et effectivement, avec ces groupes, les groupes est reconnu. Il y a des décrets ou des notes de service, effectivement, qui notifient l'existence de ces groupes de travail. Et avec ces groupes de travail qui est piloté par le directeur général de la santé publique, et nous avons des sous-accords effectivement avec ces groupes. Et à travers ces sous-accords, il y a des activités opérationnelles effectivement qui sont énumérées dans les sous-accords. Et ces activités effectivement sont mises en œuvre au niveau des districts. Donc voici un peu comment nous travaillons. Nous travaillons à travers des sous-accords qui sont préétablis effectivement sous la coupe du GTT. Et en retour, ces sous-accords sont mis en œuvre. Ces activités qui sont énumérées dans ces sous-accords sont mises en œuvre au niveau des districts et puis au niveau même national. Voici un peu comment nous travaillons dans le cadre de Inspire au niveau des différents pays du partenariat de Ouagadougou. Merci.
Donc oui, ça c'est intéressant. Vous avez ces accords et ça aide à mettre en application ces politiques. Maintenant, comment cela va se passer quand le projet sera terminé, quand les accords ne sont plus là? Comment aider à faire que ces politiques d'intégration continuent de façon, comment dire, autonome du pays, quoi. Est-ce qu'il y a d'autres moyens de redevabilité pour s'assurer que l'intégration se fasse de façon efficace ou effective?
Je peux parler? Allô?
Oui.
Oui, vas-y.
Ok, merci. Je crois qu'il y a à travers ces groupes techniques de travail qui composent effectivement les plusieurs départements qui intervient dans le domaine de l'intégration. Il y a déjà l'appropriation et même les activités d'intégration sont même intégrées depuis la planification au niveau même des districts, au niveau des formations sanitaires et même au niveau central, au niveau des directions régionales de la santé. Ils intègrent déjà effectivement ces activités dans les plans. Et actuellement, nous sommes en train effectivement d'engager ce processus de plaidoyer où ce ne serait plus Inspire, ce ne serait plus sous la coupe d'Inspire, ce serait sous la coupe effectivement des différents dénombrements du ministère au niveau du district, au niveau des formations sanitaires. Et une fois que ce processus, c'est intégré dans les plans, je me dis que c'est fini, l'appropriation est acquis et d'autres partenaires pourront effectivement les accompagner et même ça serait intégré dans les activités de routine des formations sanitaires du ministère. Et je crois que nous sommes en train de travailler pour le passage à grande échelle effectivement dans tous les districts. Et je crois qu'une fois que ce passage est acquis, ce serait intégré effectivement dans le système et c'est fini, quoi. Merci à vous.
Oui. Et donc, comme Jean-Pierre le disait, avoir ces plans intégrés, c'est une case de départ certainement. Est-ce que d'autres veulent évoquer là-dessus? Parce qu'on avait aussi parlé de la question des ressources. Est-ce que ça coûte plus de faire les choses de façon intégrée ou bien, comme le disait Dr. Shiva, il y a peut-être des moyens de s'arranger où les études ont montré qu'il y a quand même des économies qui sont faites. Quelqu'un veut évoquer?
Bon.
Oui, allez-y. Je ne sais pas qui a ouvert le micro. Quelqu'un veut? Assatou.
Oui, oui. Bonjour, c'est Aïssatou Choy de Knowledge Success. Alors, je voudrais partager une expérience. Elle n'est pas très récente, mais je l'ai trouvée vraiment très intéressante. Donc, c'est à l'époque où je travaillais dans le cadre du projet Spring au Sénégal. Alors, il y avait une certaine intégration de la santé néonatale, maternelle, donc de la nutrition, de l'APF, mais on était allé plus loin en intégrant l'agriculture. Mais juste pour s'arrêter sur la nutrition et l'APF, ce qu'on avait utilisé, il y a à l'époque une institution qui dépend de la présidence de la République, donc qui s'appelait la CLM, la cellule de lutte contre la malnutrition, et qui avait des démembrements dans toutes les régions du Sénégal. Donc, dans le cadre des activités, le portage de ces activités d'intégration se faisait par les démembrements de la CLM qui ont assuré le portage au niveau des districts sanitaires avec une implication, vraiment une très bonne implication des communautés. Et du coup, cette approche facilitait vraiment bien cette intégration parce qu'en même temps, à chaque fois qu'on devait faire des activités de sensibilisation, des activités de médias de masse, c'était avec ces agents de la cellule de lutte contre la malnutrition. Et après, quand le projet a dû se retirer, il y a toujours eu ce portage-là avec cette cellule de lutte qui est aujourd'hui devenue le Conseil national de développement de la nutrition. Et ils appelaient ce qu'on utilisait les passerelles. Et on misait beaucoup notre intervention, notre approche sur le fait que cette intégration-là également impliquée avec comme résultat l'autonomisation des femmes, qui est vraiment une grande préoccupation au niveau de nos pays. Et l'autonomisation des femmes également nous ramenait à la tranquillité même des hommes qui sont les chefs de famille, parce que quand les femmes sont autonomes, quand il y a l'APF, on prend mieux en charge les enfants, les femmes peuvent avoir d'autres activités connexes et du coup, les hommes étaient tranquilles, moins d'ordonnances, plus de ressources pour l'école. Donc, je pense que c'était vraiment une approche très intéressante et que c'est toujours important dans le cadre d'activités d'intégration d'impliquer le niveau communautaire, même si c'est vraiment gouvernemental, même si c'est institutionnel, donc d'aller du haut vers le bas pour faire avancer les choses. Merci beaucoup. L'expérience n'est pas très récente, mais elle m'a vraiment marquée. Merci.
Ouais, non, c'est très intéressant. Et je crois que le point sur l'implication des communautés, c'est très bien. Et puis, c'est sûr que on devrait encourager les communautés, les clients d'habitude apprécient l'intégration, c'est plus pratique pour eux, mais ils n'ont pas tendance à exiger ça du système de santé. Donc peut-être c'est vers là qu'on évolue, qu'on veut que la redevabilité vienne même de la source, quoi, que les communautés réclament pour ça. Et si vous avez Aïssatou, si vous avez des liens ou des ressources sur cette expérience, même si elle est pas récente, ce serait intéressant de les partager. Quelqu'un d'autre?
Oui, on a certaines documentations que je pourrais partager. Merci.
Oui, merci Jean-Pierre. Tu veux poser ta question parce que je crois qu'elle est bonne.
D'abord, concernant la culture de redevabilité, dans beaucoup de nos pays, vous entendez? Tu entends?
C'est un peu faible, mais vas-y.
Ok. Tu as bien mentionné la redevabilité. En fait, les gens ne comprennent pas toujours la notion de redevabilité. Donc, et même l'intégration aussi. Hein. Donc, il faudrait faire un effort pour cela. La redevabilité marche si vraiment c'est centré sur les besoins de la population et aussi sur les besoins des prestataires. Et parfois, on oublie ce côté-là. Mais ma question concerne quand on dit comment s'assurer que l'intégration marche. On dit qu'il faut intégrer ceci, intégrer cela, mais comment s'assurer que l'intégration marche? Est-ce en matière de performance? Est-ce que ce sont les indicateurs de deux côtés des programmes qui s'aident pour faire que ça booste les indicateurs de l'autre? Est-ce que dans ce sens, si les autres peuvent en parler aussi, c'est une bonne chose s'ils ont l'expérience. En tout cas, pour nous, avec le projet TipTop qu'on avait ici, le projet TipTop concerne le traitement préventif intermittent de la femme enceinte et on a intégré aussi bien le niveau communautaire que le niveau formation sanitaire et on a suivi des indicateurs pour la couverture en SP et aussi les CPN. Il semble qu'en intégrant les deux, ça marche très bien. Je ne sais pas si les autres ont des pratiques pareilles pour partager aussi.
Oui, effectivement, je crois que notre communauté de pratique a beaucoup débattu, mais on n'est pas encore arrivé à un consensus au niveau mondial pour comment mesurer les services intégrés. C'est pas évident. Il y a même vous avez vu dans la pratique au impact, on suggère des indicateurs à tester parce qu'on n'a pas encore vraiment validé ça au niveau international. Et le projet Inspire a aussi fait des expériences qu'on a partagées lors d'une réunion précédente. Est-ce que quelqu'un veut adresser cette question de comment savoir si l'intégration est vraiment mise en application à travers les mesures? Est-ce qu'il y a des indicateurs que vous avez vus, que vous avez appréciés? Et puis, sinon, on peut peut-être... Quelqu'un veut parler de mesures? Parce que c'est vraiment un grand défi pour l'intégration. Sinon, je vois un commentaire de Roger. Roger, je ne sais pas si vous voulez vous exprimer par rapport à cette question de capacité. Je vois que vous étiez en train d'afficher dans le chat. Roger Saïd?
Allô?
Oui, on vous entend.
Ok. En fait, je disais comme ça que je ne suis pas un praticien de la santé. Et nous intervenons dans la communauté au niveau de la sensibilisation et la mobilisation. Et à notre niveau, nous essayons de demander aux femmes, quelle que soit l'activité qu'elles mènent, d'intégrer la planification familiale à leur activité dans, comment dirais-je, dans les objectifs de leur association. Pourquoi nous le faisons? Parce qu'on s'est rendu compte que même si nous parlons de l'autonomisation des femmes, si la femme n'arrive pas à maîtriser sa procréation, c'est le nombre d'enfants qu'elle fait, elle peut être dans une activité et puis prendre une grossesse qui peut lui créer tous les problèmes. Donc, je vous laisse, en fait, j'ai écrit comme ça dans le chat pour savoir si c'est aussi une intégration, en fait, comme vous êtes en train de le dire. Est-ce qu'associer la planification familiale aux activités des femmes est égal aussi à une intégration selon le contexte dans lequel vous êtes en train de parler? Voici un peu ma préoccupation.
Oui, non, effectivement. Et puis, parfois, les groupements de mères, par exemple, les groupements de jeunes filles peuvent toucher à l'APF. Elles peuvent aussi toucher à comment donner des soins essentiels aux bébés, la nutrition. Effectivement, ce genre de groupe, je crois qu'il y a pas mal d'évidence qu'ils apportent un plus à la santé, non seulement de la mère, mais aussi des enfants. Et Karine Jacquin, je vois que vous avez mis quelque chose sur la mesure des services intégrés. C'est encore une fois du projet Inspire, j'ai pas cliqué dessus.
Oui, c'est la même chose que ce dont vous avez parlé.
Ah d'accord, oui, qui est aussi affiché dans notre, je crois qu'il y a un lien dans la communauté de pratique. Effectivement, ils ont fait des expériences assez intéressantes. Quelqu'un d'autre? Cette question de redevabilité, de comment on s'assure que les politiques ne restent pas simplement écrites sur papier, mais sont mises en œuvre au niveau décentralisé, au niveau de la communauté, au niveau des centres de santé primaires. Quelqu'un veut poser une question ou veut s'exprimer? Comment vous voyez la redevabilité des systèmes de santé en général et comment vous voyez que l'intégration s'y figure? Je vois quelqu'un qui parle de la PF, en particulier la gestion des effets secondaires. Mais on est vraiment en train d'essayer de voir comment on peut intégrer l'APF avec les conseils en nutrition ou les soins par rapport à la nutrition et d'assurer la vaccination des enfants.
Est-ce que je peux prendre la parole?
Oui, vas-y Jean-Pierre.
J'ai réfléchi un peu par rapport à la redevabilité. Il est vrai que, comme j'avais dit auparavant, que les gens ne comprennent pas vraiment ce que c'est la redevabilité. Donc, si les gens ne sont pas conscients qu'ils devront rendre des comptes à la population, au système, aux bailleurs de fonds. Et tout ça, ça concerne la redevabilité. Si les gens ne sont pas conscients, ça, c'est un problème. Et aussi, il faut, avec la redevabilité, avoir une culture de sanction. Donc, si les gens font bien les choses, ils sont sanctionnés de façon positive ou en motivation. Et s'ils font le contraire, donc, il y aura quand même des sanctions négatives, comme on dit. Mais la plupart du temps, dans nos pays, quand quelqu'un fait des malversations, il n'y a pas de suite. On le met même dans une position plus haute que l'ancienne. Et ça, ce n'est pas une façon pour favoriser la redevabilité. Ici, les gens sont vraiment conscients qu'ils devront rendre compte à quelque chose, à quelqu'un. Et je crois que nous serons sur la bonne voie. Mais il y a tout un long parcours à faire. Merci.
Oui. Donc, il faut déjà que les gens aient pris conscience de la politique d'intégration et qu'elle soit bien diffusée, n'est-ce pas? Qu'est-ce qui se passe par rapport à ça dans vos pays? On a entendu de Madagascar, mais et on a entendu des pays du PO, du partenariat de Ouaga. Comment ça se passe en RDC, au Cameroun? Je ne sais pas d'où les gens viennent, mais est-ce qu'il y a des expériences que vous voulez partager?
Il semble que tout le monde est
Ouais.
tolérant.
Bon.
Mais est-ce que la personne qui parle de la mesure peut développer un petit peu, même s'il a posé le lien, est-ce qu'il peut, quel indicateur ils ont utilisé, quelle méthodologie ils ont utilisé pour mesurer la performance de l'intégration? Merci.
Ouais, quelqu'un du projet Inspire, donc est-ce que vous voulez parler un peu plus de vos indicateurs composites? Peut-être celui qui a trait aux femmes en période de postpartum? Je sais pas, Karine ou Isidore?
Désolée, on est un peu silencieux. On n'a pas la personne en charge du MNI avec nous, du suivi de l'évaluation, mais c'est quelque chose qu'on serait ravis de partager.
Ouais, donc peut-être je vais simplement, pour répondre à la question de Jean-Pierre, je vais simplement dire que la façon dont ils ont structuré la collecte des données pour que ça demande, ça regarde le nombre de femmes, par exemple, de femmes et de bébés, parce que les soins sont intégrés, mais aussi touchent aux deux membres de ce couple. Quel pourcentage ont reçu un nombre de services dans une seule visite. Donc, par exemple, si elle venait pour les soins postnataux, est-ce que l'enfant a reçu tous les services qu'il devait recevoir et aussi est-ce que la femme a reçu ses conseils en PF? Donc, je ne me rappelle pas des détails exacts. Je crois qu'elles sont dans le lien que Karine a partagé, mais c'est une façon très différente de faire les indicateurs. D'habitude, les gens MNI disent qu'il faut essayer d'avoir des indicateurs qui ne mesurent qu'une seule chose, alors que ça, c'était le contraire. Ils mesuraient plusieurs choses dans un seul indicateur parce qu'ils voulaient voir que les soins avaient été effectivement intégrés. Mais ça demande quand même une reconfiguration des registres et de la façon dont les données sont prises à la base. Bon, je crois que on va se retrouver avec nos collègues anglophones qui vont nous rejoindre dans 60 secondes et on va pouvoir faire un petit rapportage. Je ne sais pas si quelqu'un d'autre veut rapporter ou bien je crois qu'on avait dit que la personne qui prenait les notes allait rapporter. Donc, Mathéa, je ne sais pas si tu es prête à faire le rapportage. Je crois que tu étais absente quand on en avait parlé. Ça, je le ferai parce que je le ferai peut-être en anglais pour que les autres entendent. On a encore 22 secondes si quelqu'un veut dire quelque chose. Je vois que Bina Bernadette, vous avez parlé du rôle des étudiants des écoles de médecine pour la distribution à base communautaire. Vous voulez dire quelque chose ou bien? Je crois qu'on en est aux collègues anglophones dans la salle maintenant. Hello everyone, welcome back.
Thanks, Anne.
Sorry to infiltrate your group on.
Okay, we're kind of in a lull.
Yeah, the group discussion was quite interesting.
Yeah,
Good.
definitely. A lot of input across the board.
I know that it was not a lot of time, but we hope to follow up with folks who have shared specific projects or specific resources, or colleagues who said they wanted to follow up. So we hope to do that, and we're saving the chat so we can.
Okay. So Lindsay, I think we would ask the rapporteurs, I guess, to give one sentence feedback, right, from the different groups.
Yes.
And then
the
we
moderators.
wrap up the session. Yes, the moderators. Yeah. Okay, great.
Yeah.
So I think I'll start with group number 1. That is the policy group. That will be, Lindsay, can you help me with the name of the moderator?
It's on.
Yeah, thank you. So I think I'll speak in English, but obviously our discussion was in French, and we sort of built on the words that Jean-Pierre had shared in the plenary to talk about how these policies for integrated services are rolled out, what helps ensure accountability for it. And we talked about how successful countries that have been successful on it have formed sort of integrated technical working groups that work to translate those policies into plans, operational plans, and that this helps ensure that the policy is implemented. There is still the challenge of budget sometimes. In Madagascar, Jean-Pierre says often the budget is held at the national level. So even though the decentralized or the subnational level has these integrated plans, they may not always have the resources they need to make sure they're fully implemented. And then in WAGA partnership countries, they've set up these agreements that help ensure that resources are also a help to implement those plans. And then we talked about the role of communities, that when communities are engaged, they really appreciate the integration, and that there's some really interesting experiences in various countries that we, even if they're not recent, we should keep looking back to them and learning from them. And that we hope for the day when communities who really appreciate integrations are the ones that demand it. I think we talked a little bit about the measurement challenge, which I think continues to befuddle our community of practice, that it's very difficult to know that the policy is being implemented through tracking of indicators, because we don't have necessarily the right indicators to measure that integration of services. And that's where the conversation got a little bit quiet. So with that, maybe I'll turn it over to the next group.
So that'll be Rebecca from Service Delivery.
Yeah, and actually, I think it's going to be Sasha Lamstein that is going to be reporting out. Sasha?
Okay.
Sure, I'll give it a shot. Although, Rebecca, I think you did a nice job summarizing as we went. Let's see. I have in my notes, I have lots of different notes. I would say we didn't get too far in all of the questions. We had a number of really interesting questions that I think are actually worth repeating. The questions were, what are the biggest barriers to integration at the service delivery level? What types of tools and guidelines exist for integration? And what are the tools and guidance lacking that, if provided, could help? And then how has COVID-19 impacted the way integrated services are prioritized? So I'm just mentioning them because I think it's useful for all of us to think about. And if other people who weren't in our group have comments, they would be well received. Some of the things, we really only got to the first question and we kind of shifted around. We've heard about a few interesting guidelines from Nigeria. The integrated training guideline for primary healthcare workers has been very helpful. Also in Nigeria, what was mentioned was the I'm not sure if I can find it right now, but the job shifting, job sharing policy from the government, which helped sort of validate empowering lower level health workers to provide some of these services when to ensure that they were available. I hope I captured that correctly, but we also talked about the importance of trust, trust in the services provided. That's a common one that we talk about. And the need, the challenges, some of the hidden challenges to accessing services that could be overcome. There was a nice example shared, and I'm sorry, I'm not getting everybody's names, regarding where services are integrated. So in Bangladesh, in some of the refugee camps, they made a point of integrating services at the mother groups, or where midwives were. And sorry, I heard someone speak up, and that really helped achieve better immunization, like for COVID vaccinations, by having the midwife help to do that. So I think that speaks to, you know, increasing the trust, overcoming some of these barriers to utilizing services. I'm trying to think if there's anything else that jumps out at me. Obviously, there wasn't much time. Rebecca, was there anything that jumped out?
Yeah, Sasha, just one other thing. Thank you so much. Just one other thing I would mention that came up is that while there may be broad agreement in principle of the appeal and the importance of integration, the reality is that many programs are driven by the expectations and the funding and the accountability that is imposed by different funders, and that is a reality, and that's something that requires really developing consensus across those different big picture players to try to see how to go from just talking about integration to actually enabling funding to be used in ways that supports it. We also had a very interesting comment at the end about defining terms. What do we mean by integration as opposed to by bundling of services, or perhaps by linking of services? So those were just a couple of other things that came up. Thank you.
Yeah. Thank you, Rebecca. Yeah, those were good points. Great. Turning it back to you.
Thanks so much, Sasha and Rebecca. So I'll turn it to Dr. Saga and the team from the third group, and Brittany.
Thank you, Chizova. We had a really great discussion. We also similarly didn't get to all of the questions, but we really started looking at, our group was focused on communication and trust building for increasing demand generation for integrated services. And we really started looking at it from the perspective of increasing demand activities that respond to the specific and diverse needs of communities, and ensuring that that is the main and foremost consideration in any sort of demand generation activities. We also discussed that demand may be uneven within health areas. While demand may increase for a specific aspect of a health topic area, that might not mean that there's demand for that health topic area more generally in the community. To take that into consideration when planning sort of integration activities, communication around integrated services. And we left our discussion considering the question and diving into a little bit more around increasing demand generation and really looking at government attention and support of integration as one way in which to increase this demand for integrated services. So really having and centering the government role or the policymaker role in increasing demand for integrated services, and any examples of successful advocacy around that. So Lindsay, anything else that you'd add, or anyone else in my group that you'd add?
I think that was a good summary.
Okay. Thank you so much to all the presenters, the panelists, the discussants in the breakout groups, as well as the facilitators and the rapporteurs. I think this has been a rich discussion, and what I came away from this discussion learning is that integration is something that we all think is a great thing to do. We all want to do it, but there are several challenges, and challenges that range from the policy level to even the way programs are structured. They're structured to be siloed, but then we don't have the accountability. So we want to do integration, but we don't know how to measure integration, and we're not necessarily providing all the resources, both financial and human, to do the integration well. So I think with that, I would say that this community of practice is certainly a place where we can come to get inspired and learn some more and continue to push and find the boundaries that will help us get the integrated services that we think are the right of the people that we serve. So thank you so much, everyone. I will now hand it back over to Lindsay.
Great. Thank you so much, Chizoba, to our panelists, to our moderators, and thank you for everyone who participated in the breakout groups. The discussion was so rich that we are very much over time, and we had a few more activities that we wanted to share with you and a few more opportunities to engage. So we won't be able to do that now, but we will follow up via email. I think Chizoba has done a fantastic job of sort of summarizing, really the meat of today's meeting, which was our presentation and our rich discussions we had in our breakout groups. After the meeting, I will follow up directly with you all to share some of these opportunities. There are multiple global platforms that the community of practice uses to communicate with each other, to share resources. There were a lot of things that you all shared today that we want to follow up and be sure to share with our global community. And if you want to join the community of practice directly. So with that, I will say thank you so much again to the Community of Practice Steering Committee, for our panelists who join us around the world, for everyone who joined us. We were up to 170 participants at one time, so really excited that you all are as excited as we are about this topic. And so thank you all, and we will be in touch. And most importantly, we'd love to hear your feedback on the meeting. So please fill out the survey that we are going to share in the chat, and we will be in touch. Thank you so much, everyone. And we'll see you in 6 months.
Thank you, everyone. Thanks.
Thank you.
Yeah, thank you very much.